Welcome to this presentation. I'm Dr. Katie Pink, a respiratory consultant working in Cardiff, and during this session I'm going to provide a brief update on the All Wales Adult Asthma Management and Prescribing Guidelines. To set the scene, we have a high prevalence of asthma in Wales and unfortunately poor asthma outcomes, with high numbers of asthma deaths and poor levels of basic asthma care, highlighted in audits such as the National Respiratory Audit Programme and surveys conducted by Asthma UK. The National Review of Asthma Deaths in 2014 identified 2/3 of asthma deaths as being preventable with better access to basic care and by adherence to guidelines. In the UK, as we'll discuss, there remains a reliance on reliever rather than preventer medication, and this is a key driver behind the changes in the prescribing guidance. This is the single-page summary of the All Wales guidelines. They've been developed by a multidisciplinary group of clinicians in Wales that work across the primary and secondary care interface. They've had wide stakeholder review and were endorsed by AWMSG in February 2024, and they build on previous versions. The main change in the current guidelines is around the management of mild to moderate asthma, with the introduction of anti-inflammatory reliever therapy, which involves using a combination inhaler containing both inhaled steroid and formoterol, a bronchodilator, on an if and when needed basis. And Symbicort was the first agent to be gained a licence to be used in this way, and this was in spring of 2023. The guidelines have been heavily influenced by the recommendations and the guidelines produced by GINA, the Global Initiative for Asthma Strategy. The current NICE guidelines are outdated. However, there are updated recommendations due to be published imminently in combination with SIGN. And having had sight of these draft guidelines, I'm pleased to say these also support anti-inflammatory reliever therapy as a preferred way of managing asthma. So the All Wales guidelines have been split into a preferred pathway at the top, and also we've left in a more traditional treatment pathway at the bottom. And it's recommended that this traditional pathway is reserved for those patients who are very stable on their current preventer inhaler with good adherence, no exacerbations, and rare use of short-acting bronchodilators, so less than 3 SABA inhalers a year. The guidelines follow a stepwise approach and continue to separate inhaled therapy options into dry powder devices and MDI devices in order to aid clinicians in choosing the right inhaler device for a patient when stepping up and down the treatment ladder. There's a continued drive to promote greener prescribing with green and red footprints to indicate those inhalers that have got high and low global warming potential. The guidelines highlight the need for an accurate diagnosis using objective tests. If the diagnosis is inaccurate, then no matter what treatment is started, control will not be achieved. And studies suggest that approximately 1/3 of patients with a diagnosis of asthma do not have any current evidence of the condition when objective tests are performed. Over the last 50 years, we've really changed our understanding of asthma. We now know it to be a disease of airway inflammation rather than bronchoconstriction, and therefore it needs to be treated with inhaled corticosteroids. And this is really a core principle of these guidelines. Older guidelines only recommended stepping up to inhaled corticosteroid therapy once symptoms were uncontrolled 3 or more times a week. Over recent years, most guidelines have actually changed and have recommended that all patients are prescribed inhaled corticosteroid. But in practice, there are still many patients on SABA monotherapy, particularly those that have infrequent symptoms. And in addition, we know that poor concordance with inhaled corticosteroid therapy is also widespread. And this is important because studies show that even patients with very mild symptoms, so less than once per week, can still have severe or fatal exacerbations. And starting inhaled corticosteroid therapy in this group does reduce the incidence of exacerbations. And many studies have shown that in the UK there is an over-reliance on short-acting bronchodilators, and it's much worse in the UK compared to many other parts of Europe. And this is at all treatment steps. And for example, the Sabina study showed that the need for 3 or more SABA inhalers per year is associated with worse outcomes and an increased risk of exacerbations. But despite this, about 38% of the UK population with asthma are prescribed this. So by switching patients to this new preferred regime with an increased use of combination ICS formoterol inhalers, we should not only improve asthma care, but also reduce reliance on SABA and reduce the risk of exacerbations. We also know that actually salbutamol MDIs are the key contributor to the NHS carbon footprint, and hence these updated guidelines really support the NHS decarbonisation strategy as well. So individuals with mild asthma should be started on anti-inflammatory reliever therapy. And this involves taking a combination inhaler containing ICS and formoterol on an if and when needed basis in response to symptoms without the need for regular therapy. Of note, only inhalers containing formoterol can be taken in this way, as this is a long-acting bronchodilator with a very rapid onset and it acts in a very similar way to salbutamol. The main randomised controlled trials were done using Symbicort, and so this was the first inhaler to gain a licence for anti-inflammatory reliever therapy, although it's likely that many of the bioequivalent drugs will also follow. The evidence of all these trials has been evaluated in a Cochrane review, and the summary is that compared to SABA alone, anti-inflammatory reliever therapy decreased the risk of exacerbations, including severe exacerbations requiring admission or A&E attendance. When you then compare anti-inflammatory reliever therapy to the use of a regular inhaled corticosteroid with SABA therapy if and when needed, we found that anti-inflammatory reliever therapy was non-inferior in terms of overall exacerbation risk, but importantly it did reduce the risk of severe exacerbations. And this was despite an overall lower annual steroid burden in those using anti-inflammatory reliever therapy or AIR. There's qualitative evidence, in addition, that many patients like this approach and they prefer it to the need to take a daily ICS. It's quite a natural way of using an inhaler. So AIR therapy should be started in those with mild, infrequent asthma, with symptoms certainly less than 4 to 5 days a week, no nocturnal waking and no recent exacerbations. For those with moderate asthma, the guidelines recommend the use of ICS formoterol as a regular therapy twice daily, with extra doses as needed, the so-called maintenance and reliever therapy or MART. And you'll all probably be familiar with this. This has got grade A evidence in reducing exacerbations compared to fixed dose ICS LABAs with SABA as a reliever. And patients should start at this treatment step if they've got symptoms most days, if they're waking at night with their asthma, or if they've had a recent exacerbation. The difference between step 2 and step 3 is really the number of maintenance puffs taken, with 1 puff twice daily at step 2 and 2 puffs twice daily at step 3. Montelukast can be added on and is especially useful for those with allergic-driven asthma, exercise-induced asthma or rhinitis, and it should be stopped if there's no benefit after 6 weeks. And Spiriva is another add-on therapy that can be trialled at step 4. It's particularly useful for those who've got more fixed airflow obstruction or COPD overlap. We're all quite used to assessing control for patients managed on the more traditional regime. So we would note that if an individual was needing 3 or more reliever doses a week of their SABA, that would indicate poor control. For those using the anti-inflammatory reliever therapy, of course, each extra dose taken provides additional controller medication in addition to the reliever agents, and hence it helps to prevent exacerbations. And because of this traditional cut-off of more than 2 doses of reliever therapy per week indicating poor control doesn't necessarily apply. What we need to really think about is the average frequency of reliever doses of ICS formoterol that have been taken over a 4-week period. And persistent rescue doses beyond the maintenance over a longer period should prompt consideration of a step up in therapy. This study from the European Respiratory Journal suggested that as a guide, perhaps individuals needing 7 or more rescue doses a week should be considered to be stepped up. But I think this is still an area where we need more research. And finally, the pathway highlights those patients who should be referred to secondary care. So the main indications relate to diagnostic uncertainty, complex comorbidity driving symptoms, suspected occupational asthma, or poor control despite adherence with step 4 asthma therapies. Of course, we now have biologics available for severe asthma, and there's still an unmet need for these therapies, with many patients in primary care who would benefit from identification and referral. And there is a national drive to try to increase access to these life-changing medications. So particularly those individuals that are having 2 or more exacerbations requiring oral steroids, despite optimised primary care management, really should be referred. The guidelines do highlight that a trial of high-dose inhaled corticosteroid LABA can be considered prior to referral. And it also highlights that these high-strength inhalers cannot be used as a reliever, so part of the MART regime. And if we are stepping up to high-strength inhaled corticosteroid, a short-acting bronchodilator will be required. So this change in management is going to take some time to implement. For new asthma diagnoses, it should be quite easy to start patients on the preferred pathway with anti-inflammatory reliever therapy or MART-based therapy, dependent on their symptom burden. For established patients, it's important that control, exacerbation frequency and SABA prescriptions are considered at an annual review. And if poor control is identified, patients should then be switched to the preferred regime. And the same applies for anyone being seen with an exacerbation. There's certainly an opportunity for proactive identification of high-risk patients in primary care through audit. And I would suggest that search criteria could include those on SABA monotherapy as a priority who should be switched to air, those with a history of recent exacerbation within the last 12 months, and those with a history of SABA over-reliance, particularly if there's objective evidence of poor prescription ordering with inhaled corticosteroids. And just to finish, I wanted to highlight the wealth of supporting resources that have been produced alongside these guidelines. There are extensive supporting notes linked on the AWMSG website. In addition, the guidelines were developed with support of a company, ICST, which has produced a toolkit of educational resources, including webinars aimed at both healthcare professionals and patients. And we've also got the Health Hub Patient Self-Management app that's got a lot of information aimed at patients, because we realise this is quite a big change in management for patients. There are updated posters being printed currently of the guidelines, and these are going to be sent out to all GP surgeries. And in addition, Asthma UK has a wealth of information on their web pages on anti-inflammatory reliever therapy, including more traditional paper-based action plans. Thank you.